Hi, everyone, and thanks for joining the first webinar of Family Medicine for America's Health. We have Dr. Glenn Stream with us today, who is the chair of the board of the organization, and I'll go ahead and turn it over to him to get started.
Great, thank you, Kirsten, and welcome everybody for joining our webinar this evening. I'm very glad to have you join us so that we can talk and learn a bit about the Family Medicine for America's Health project. At the end, we'll be having an opportunity to take your questions, and so if you have questions that come up as we go through the webinar presentation, you can type your question into the chat feature of this platform, and then we'll have an opportunity to answer a few of those questions towards the end. So a little bit about myself. I'm a family physician. I practice in La Quinta, California. I previously practiced in Washington State my whole professional lifetime, but recently relocated here. And I was president of the AAFP 2 years ago, and currently chair the Family Medicine for America's Health Board of Directors, and I'll talk about the organization a little bit as we go through the presentation. So the goal, if you want to put it up in one word, of our effort is to transform the specialty and the healthcare system with a renewed focus on health, the health of the population of our country, because we all know the health challenges that our population faces and that we face every day in the care of our patients. So this health is primary emblem thing that you see here. I'll talk a bit more about that as we go through. So I'd like to talk a little bit about how we got to this point. As you're probably familiar, over 10 years ago, the specialty of family medicine went through inward-facing evaluation process in the original project. So that was conducted between 2002 and 2004, and its report was published in April of 2004. So over the last 18 months or so, we had discussions within the organizations that we often refer to as the family of family medicine, and I'll show you those organizations in a moment, about with the 10-year anniversary of the future of family medicine, would it be time to revisit some of those questions, review our progress to date, reevaluate the landscape, and identify where do we go from here. So based on those discussions, it was decided, in fact, that's what we should do. And in August of last year, 2013, we kicked off what for quite some time was referred to as the Future of Family Medicine, or FFM 2.0. And again, not to redo the work at all of the original Future of Family Medicine, but to reevaluate its success to date, how the environment's changed, and what's our course from here. So that effort concluded with a recommendation to the sponsoring organizations in April of this year with the recommendation to form this new entity, Family Medicine for America's Health, and to proceed forward with some certain strategic goals and communication efforts that is the purpose of tonight's presentation, to review those. So these are the 8 sponsoring organizations. 7 of them were the original organizations involved in the first Future of Family Medicine project. In this project, we are very grateful to have the participation of the American College of Osteopathic Family Physicians and their contribution to this effort. So now these are the 8 organizations who have evaluated and approved the strategic plan for Family Medicine for America's Health and the communication strategy around the project going forward. So these organizations collectively also committed substantial financial resources to support this project. These organizations span significant size differences and have substantially different financial resources, and yet all really dug deep into their reserves to support the project. And we have a budget currently of over $20 million for the 5-year effort. So each of these organizations selected a member from their organization to serve on the Family Medicine for America's Health Board of Directors. Additionally, we felt it was important to have some other voices at our board table. And so our board consists of those 8 organizations. I represent the American Academy of Family Physicians. And then the other 4 board members, we have one representing early career physicians. We wanted very much to have the young physician leader, young family physician leader voice represented on our board, and Dr. Lauren Hughes, who's currently a Robert Wood Johnson Foundation Fellow at the University of Michigan, is our young physician participation, early career participant. We felt it was extremely important to have participation by a family physician in a solo or small group practice, ideally in a rural area, ideally practicing full-scope family medicine, and we were very pleased to have Dr. Jen Brule from Plainview, Kansas, who's in a solo practice, delivers babies, does hospital and emergency room care, and she's participating in our board. The strength of our organizations is very much in part through our chapters as far as the American Academy of Family Physicians is, and so we really felt the need to have chapter representation, and so Vince Keenan, who's the chapter exec from Illinois, has been a very active participant in our board. And then finally, the 12th person, we felt it was very important because we had identified the need for this effort to be very patient-centered and patient-focused, to have a patient advocate participant and representation on our board. And so Lauren Kennedy, who's the Director of Advocacy for the National Partnership for Women and Families, is a member of our board and has brought a great voice of patient perspective and advocacy to our board. So that's our board as we go forward. Just some administrative issues. To get this stood up as quickly as possible, it was decided to create the entity that is running the project as a separate corporation, and so it is set up as a limited liability corporation within the American Academy of Family Physicians, very similar to how TransferMed operates in its work. And then we have administrative services provided to the project, both by the AFP and the AFP Foundation, and that combination brings us a really significant breadth of resources. The 501c6 status of the Academy that allows certain advocacy resources and has deep staff expertise that provides us accounting and legal support and those really necessity functions of any activity. And then the Foundation has a lot of experience with strategic partnerships and has the not-for-profit 501c3 eligibility that allows some flexibility to our entity. So that's the construct for the organization as it moves forth in doing its work. So just some background, and I understand completely that this is preaching to the choir when I'm talking to practicing family physicians, but we know the struggles that we have as a country with health, with our healthcare delivery, and our efforts as family physicians to try to make the best out of a dysfunctional system. But, you know, spending is out of control. It's a significant stress on federal and state governments, local governments, businesses, and individuals. You know, we know that the #1 cause of bankruptcy in the United States is medical debt, and over half of those people have health insurance, and it's just the uncovered expenses that will force them into debt. So that expensive system is just simply unsustainable. And despite having spent that much on healthcare, you are familiar with hearing these statistics all the time about how we fail to achieve the same degree of health in our population as other first world countries that spend substantially less per capita than we spend. So that's the challenge that faces us. And you also are very familiar about how our system is upside down. We spend far too little on prevention and wellness and good chronic illness management, and spend way too much money on treating late-stage illness that could have been prevented. And personally, I was stunned by this statistic that 75% of our healthcare costs are spent treating what could have been prevented. And so if our system was to invest more substantially in the prevention and wellness and good chronic illness management that we can do as family physicians, it will contribute to the improved health of our people, but also help to avoid unnecessary costs. So this slide was prepared for me, and I sort of had to pause when I read it first, that we've lost our focus on patients. And I'll tell you, I don't believe for a minute that we as individual family physicians have lost our focus on patients, but I think we all experience that the healthcare system does not focus on the best needs and interests of patients. It's often disorganized and complicated by prior authorizations for medications and referrals and treatment that just shouldn't involve that degree of complexity in our patients getting the care that they need, and that their care is often fragmented between different specialists, different locations of care, and this is a substantial flaw in the system that gets in the way of us being able to deliver on improving people's health. So you're probably familiar with the concept of the triple aim. So this came from Dr. Don Berwick and his colleagues at the Institute for Healthcare Improvement, and it's a simple but elegant concept, the idea that our system needs to evolve to deliver better care, safer, high-quality care, more accessible, and it needs to deliver better health, actually improving the health status of the people of our country. But in doing so, it also has to lower costs, because the cost of our healthcare system is not just bankrupting entities like I mentioned, but it's drawing resources away from other areas of potential public good. We're not spending enough on education and parks and other areas that contribute to public good because the bank is being drained by healthcare costs. So this concept of the triple aim in our discussions in the development of this project was really identified as a tectonic movement within our healthcare system. There is a lot of recognition across the public and private sector, across different segments of the healthcare delivery system, that this is what we need to accomplish. But you and I know that we cannot accomplish this without a very strong primary care foundation. Without primary care, you don't have the adequate prevention and wellness. You don't have good chronic illness management. You don't have good access to early treatment of acute illness to prevent later stage illness. And so we really need to pursue these goals in the efforts to address improvement in our healthcare system, and that by doing so, this really advantages family medicine and other primary care disciplines, because these goals, the triple aim, cannot be achieved without that investment in a strong primary care foundation. I would add one caveat to that, and that's often what people refer to as the quadruple aim, and that's adding in the fourth component of professional satisfaction. We often read surveys of our colleagues and how they're professionally dissatisfied and frustrated, and even to the point of burnout. And the efforts that we make to improve our healthcare system need to not just improve quality, improve health, and reduce costs, but they have to make the practice of medicine for family physicians, for our colleagues in other specialties, our other colleagues in other healthcare disciplines that are part of the patient-centered medical home, medical teams, and our extended medical neighborhoods. We need to improve the satisfaction of people who do this very important work. So the idea behind Family Medicine for America's Health is a broad strategic effort focusing on those goals. We want to continue to expand and in many ways improve and evolve the medical home model. It's made a lot of progress since its birth, really, in the original Future of Family Medicine project and the development of the joint principles in 2007. But any system can improve over time. particularly I believe in the interdisciplinary practice and the training that can support interdisciplinary practice and allow us to do better care. And so a focus of this effort is to participate in that continued evolution with very much a goal towards addressing people's concerns and reservations about the model, and to use health delivery research and other evidence-based methods to really evaluate not just the healthcare we deliver, but the model with which we deliver it, so that we are actually having a quality improvement effort around this delivery model. We believe that there is an opportunity for family medicine and primary care to really be identified as at the forefront of the continued implementation of healthcare technology, particularly patient-facing technology. So the explosion of apps that patients use to monitor their blood sugar and blood pressure and weight and diet and all of those things, and the even more interesting explosion, I think, in wearable recording devices that track people's steps and their calorie burning and their activity levels, and eventually they'll have more biometric information as far as pulse rates and blood sugar and those sorts of things. But those technologies, as fascinating as they are, if they don't actually contribute to people's health, it's just flashy technology. We want to be part of a dialogue with patients and with the technology sector in evaluating these technologies to identify which ones really work well, which enhance rather than complicate the patient-doctor relationship. How do we handle and respond to this information without increasing the information overload that we as physicians deal with? So we want to be part of that dialogue. We really have to focus on a strong primary care workforce, and that extends across the entire spectrum of what we often refer to as the pipeline of workforce development. It's all the way down to junior high and high school, identifying people that have an interest and aptitude, particularly if they come from rural and underserved areas, to be motivated and inspired about a medical career, to get into college and graduate primed to go and be successful in medical school. Have medical schools focus, again, on people who have the interest and aptitude to be primary care physicians, and have them have that as a priority for their school to produce the workforce that our country needs, and to sustain the interest of those folks interested in primary care through their medical education. We need an adequate and robust graduate medical education training in residency programs that trains people in the appropriate scope of practice. We very much believe that we need to continue to train family physicians in a broad scope of skills so that they can meet the needs of whatever community that they choose to serve, and that might be different for each of us, and it may even evolve over our careers, but they need to be able to deliver babies. They need to be able to do hospital care when they graduate, whether they then ultimately do those in practice or not. And then I think often a neglected piece of that pipeline is we really need to focus on what I mentioned earlier, which is that professional satisfaction of practicing family physicians, so that we don't lose people from our workforce because they're burned out and dissatisfied, but rather that they remain practicing because they're feeling fulfilled and enjoying their practice. And then the last part I'll highlight a couple times is that we absolutely believe for any of these other things to happen that we have to change the payment system that supports primary care. The fee-for-service system that requires us to record in our electronic health records X number of bullets for review of systems and physical exam and history just to get paid a small amount, and then a claim goes back and forth and ultimately gets paid at a reduced level. That's waste, and it's waste not just for our practices, it's waste for the payers, it's waste for the patient, and what we need is a payment model that is appropriate for primary care. So I would like to say that I hope not to need any orthopedic or cardiac procedures or need organ transplant or any of those sort of health disaster type of things. Those are what insurance is for, and it may be appropriate in a bundled way to pay for those services in some adjusted fee for service. But what the care you and I deliver, the bundle for that is a month or a year of caring for a person with a certain mix of health problems, and paying for that separate from a fee-for-service system, more on a predictable month-to-month, per member per month, not a global capitation for all of their care. We have no interest in going back to the disaster of the 90s as far as global capitation and the effect it had on practices and doctor-patient relationship, but rather a guaranteed payment per member per month that supports the practice to deliver the care through the entire team in the medical home model, to deliver the care that people want to deliver and that the patients deserve. So the process over this roughly year-long plan development was to develop this strategic plan aligned with the triple aim and with the goal of meeting these health needs of the American people. So we have 7 core strategies, and I'll show you those in a moment, and they have 28 tactics at this point that support those strategies. And as you might imagine, some of them cross over different tactic areas, and I'll talk about that in a minute. But I would highlight, and I'll say this again a couple of times, this is not an effort that family medicine can do on its own. We are an important force in the healthcare system. If you add up the collective membership of those 8 organizations that I showed you, I don't know the exact number, but I'd say it's in the 250 to 300,000 members. That number of physicians representatives makes this a significant effort, and yet collaboration in certain areas with our colleagues in other primary care specialties, with other physician specialties, with other members of the healthcare team in other disciplines, including nursing, nurse practitioners, physician assistants, dietitians, pharmacists, health educators. All of those folks are an important part of the system, and in different areas we'll have the opportunity to collaborate with them where we have mutual interests. So published 2 weeks ago, today I believe, was the article that describes the work of the development of this project, both its history, some ideas behind it, some of the information that supported the development of this plan. There was a great deal of research, both qualitative and quantitative research, surveys, focus groups, one-on-one discussions. There was a large stakeholder retreat where we had 110 representatives, only about half of which were family physicians, the other half people in other stakeholder groups, medical, payers, government, patients. All of those represented that informed this work as well, and then some ideas about what the plan looks like going forward. So that's all in this supplement to the journal, The Annals of Family Medicine, and the URL is there, or you could just identify it off of the journal's website. But I would encourage you, if you're interested in where did this come from and where's it going, there's more information there about the project. So these are the 7 core strategies that were the recommendation for this strategic effort. Some of them we've talked about a little bit, but I'll highlight them again. The first one, show the benefits of primary care and its value, is both a talk the talk and the walk the walk. There's a communication effort, and I'll talk about it in a little bit more, to educate important stakeholder groups. So that's patients, government, health plans, employers, all of those folks about family medicine and what its role is in delivering high quality care and improving health, so that we really have that better understanding in those stakeholder groups and makes them more open to the suggestions that we have about how that system needs to change. This area of educating folks about understanding what family medicine is and what family physicians can do was identified as something we weren't as successful as we would have liked to have been in the original Future of Family Medicine project. So we're going to invest significantly in that, and I'll talk some about that. Our goal is that everyone should have a personal relationship with a trusted personal physician, ideally a family physician, but most importantly, a primary care practitioner in a medical home model of delivery. And that's the mechanism by which we are going to be able to improve health and lower cost in delivery through that model. Achieving the triple aim, I've talked about that. It really is aligning all of this effort with improving health, improving healthcare delivery, and reducing cost. We have a significant interest in reducing healthcare disparities. So if we, as family physicians, are truly focused on the health of the people we take care of, their health care is only part of that. The issues around the social determinants of health, education, personal behavior like alcohol and smoking, environmental things about air quality, water quality, all of those things contribute to people's health, and we need to have a broad perspective and a broad participation in improving globally people's health. I mentioned leading the continued evolution of the patient-centered medical home. Obviously, that would be in collaboration with our other primary care colleagues, but again, not accepting that it's as good as it can get and wanting to address the concerns by many of our colleagues about the model, and particularly around certification and how do we deal with that. So very much work to be done there. The well-trained workforce I mentioned as well, this whole pipeline of an adequate number and the right scope and depth of training for our family physicians. And then again, I'll highlight this linchpin component, which is the payment model. We have to have a payment model that supports this healthcare delivery system of primary care and family medicine in the medical home model, or the rest of this simply won't happen. So we have 6 tactic areas that involve addressing these strategic priority areas. So their broad areas of focus are practice, workforce, technology, research, payment, and engagement. So engagement, very much our connections to the public and to government and to our colleagues in other specialties. A real focus on the patient engagement. We would like to see every practice have a mechanism by which to receive feedback from the patients it serves. If it's a large enough practice, that might be a patient committee. It might, in a small practice, be an individual person. But to give us feedback about how can we serve their needs better, because often what they identify as important and meeting their needs is something we might not have thought about. So this collaboration with patients is something that I just can't emphasize enough the importance of it. Sorry, I was interrupted for a moment. Shouldn't do this from my office. So the payment model we talked about, research really is both research about the healthcare delivery and research about the medical care delivered in primary care practice. We all know that National Institutes of Health funding tends to predominantly go to really high-tech, genomic, device, surgical, robotic sorts of things. And yet it's the everyday things that you and I treat that often have the greatest impact on people's health, and yet we may not have all of the science behind that that we need. So we want to very much have a more organized focus around that research. Actually, I'll mention this is an area where there's a potential for your participation, and I'm going to highlight that at the end. But we have a core group of folks working on these tactic teams, a core group of 5 individuals for each. But the idea is to build an extended network around these tactic teams, people with unique perspective, knowledge, ability to contribute that would help move us forward. So Health is Primary is the communications campaign and strategy, and I'll show you some individual ads and a video in a moment. But the idea is to really focus our communication strategies on patients and on their health, and by doing so, to highlight the role that their primary care physician and that their medical home plays in their health. And again, to have them understand that, to be better engaged and more effectively engaged with us as far as achieving their best health, but also then that they can become our advocates in the efforts that we need to undertake in areas of reforming the healthcare and the payment system. So the play on words is intentional. Health is primary, primary care, brought to you by America's Family Physicians, and the idea of that sort of becoming universal locator icon, that's the dot on the I as a eye-catching thing for it's at your medical home that health is primary. So I'm going to show a video that was launched at a press event 2 weeks ago that was the launch of this communication campaign. And if I can make the technology work. I think I may have closed the wrong thing. I thought I was just closing the video. There you go. Perfect. Came back. Good. So I couldn't hear the sound. I hope you could. I think it may just not have been playing for me as presenter, but the video is on YouTube, and I'll ask staff to post that URL in the chat. And oh, good. Somebody said they heard it fine. Good. But you can get that. It is just out on YouTube, publicly available. If you just search under Health is Primary, it'll be one of the ones that comes up. So I'd encourage you to do that and spread the word. It is also on a website towards the end that I will show you. So these are the core elements of the communication campaign. Very much, again, what I mentioned is having a health and patient-faced focus and getting that message out about how that relates to their primary care. So the patient outreach will have tools and resources that relate to a couple topic areas in this first year. I should pause for a moment and talk about that the communication effort is planned to be a 3-year effort, and so this will be a sustained effort. And then the strategic plan has a 5-year timeline. So the patient outreach about important health issues smoking prevention, health and wellness, immunizations, chronic illness management. Our role as family physicians and particularly managing people with multiple chronic illnesses is a unique role that we bring to improving people's health. The concept of community engagement is that we know that there are great success stories to be told in areas of the country where the family physicians in that community, in collaboration perhaps with public or mental health, employers, schools, health plans, whatever the multi-stakeholder effort involved, that had real success in improving improving access to primary care in those communities. So we will have what we call a city tour, where we're going to go out and participate in those local areas in telling their story and highlighting that success and being able to hold that up as a model and provide some resources to help other communities and other physician groups to duplicate that effort in their community. And again, the concept around technology, this thought leadership, we envision currently that starting in the within the AAFP's Alliance for eHealth Innovation and potentially grow from there. But again, an opportunity for collaboration with our colleagues in other specialties and particularly to engage the technology sector. So as the chair for the Family Medicine for America's Health, I'm going to have an opportunity to go to the Consumer Electronics Show in Las Vegas, which, as some of you probably know, is sort of the big show where people roll out their latest and greatest consumer technology. And the goal is to start that dialogue with these groups about how do we work together to identify those technologies that patients and doctors can use together, again, that aren't just slick and cool, but actually can have some evidence of their ability to contribute to improving people's health. So these are some of the specific ads so far that are developed in the communication campaign around this health as primary theme, this concept of family physicians as innovators, which I know we are, that we have that personal relationship with our patients and we know their name, this focus on prevention and wellness, which is very much a focus of what we do in our daily practice, this connecting the dots piece, which is not our patients as a sum of their organ systems, but rather them as a whole individual in integrating, coordinating, and personalizing their care. This forest for the trees, again, seeing them within the healthcare system, that face time that we know is just as important between patients and doctors as far as their care, but extending it to even include communication and connection with our patients using technology as long as the payment model supports that. Everybody wins is really sort of the triple aim idea, is that having better health care, and reducing cost. And then again, this focus on the healthcare team, us working and providing leadership to healthcare teams in primary care practices that include folks in other health disciplines, but that working together we can more efficiently and with greater, again, professional satisfaction deliver care to those folks. Some more of the materials that align the message with this triple aim concept of better primary care, improves health outcomes, and reduces costs. So these are photos from our press event launch that was 2 weeks ago, and we were very fortunate to have with us Dr. Don Berwick, again, who sort of the father of the triple aim concept, and he had very interesting remarks for us. He was very supportive, and yet was challenging in us not thinking too small in the scope of work that needs to be done, and that there is a window of opportunity, and that's how we have recognized this as well. It's a window of opportunity. People are looking for someone to step up and lead change in the healthcare system, and a remarkable number of people think that in fact is the specialty of family medicine to do that. Again, very supportive of that concept, but he says, don't dawdle. We got we mentioned the 5-year timeline, and he said that's about right. That's about how long you got to fix it. Or the big, heavy-handed, crude instruments of government regulation would come in and force our hand in a way that none of us would want. So the other person that was able to be there is T.R. Reid, whose book, The Healing of America, was a bestseller in 2009, based on his experience having lived as a author and reporter in other parts of the world and experiencing their healthcare system, and his observations about how our healthcare system should evolve and, again, to be more patient-centered, more prevention and wellness focused, and again, very complementary and encouraging to our efforts, and both have offered to remain engaged in an advisory, unofficial advisory capacity to give us some support as we go forward. So we've got some very good press about this event, some good feedback from both regular news sources, but also from medical reporting, from our colleagues in other specialties, supportive of our effort and our initiative to step up and to lead an effort like this, recognizing how ambitious it is, and recognizing, again, that we need to work together, that there's a collaboration that is absolutely critical to make this a success. So again, some more media coverage. We actually had an article in the Washington Post, which, since we were in Washington, D.C., is pretty much hitting the home run during a political campaign to get coverage in a highly respected national publication like that, and very much the concept of the patient-centeredness, the alignment with the triple aim about redesigning the healthcare system to be more prevention and wellness focused really resonated with the folks. So some milestones that will be coming up. Obviously, the media campaign launched just last month. In January, we'll be having a focus on prevention and wellness around the nutrition and exercise type of topics, which is always sort of a timely January New Year's resolution sort of a focus. In alignment with the Great American Smokeout, a focus in March on smoking prevention and cessation. In August, aligned somewhat with the return to school, but also the early influenza season sort of focus on upcoming immunizations. Obviously, we have work to do there. We know in the public that there's lingering reservation about immunizations, and we want to be one of the voices of reason that is out there promoting that important wellness aspect of people's care. And then again, we'll be having these city tours. We plan to hit 5 or 6 cities next year as far as identifying those success stories in improving health and improving the healthcare system in different areas that can be models for other areas, and then brought up to scale to make more of a national transformation effort. So that's about the campaign, both the strategic and the communication aspects, and what our plans are for the near future. Again, the communication strategy having just kicked off and planned as a 3-year effort, so there certainly will be more to come, and would encourage you to stay tuned. Around the communication strategy, on Twitter you can follow the @HealthIsPrimary and the Facebook page for Health is Primary, and the communication and patient-focusing web presence is at this healthisprimary.org site. This webinar is being recorded and will be made available there later this week, and so if you're interested in recommending this to a colleague, I would very much appreciate any effort that you can make to get the word out about what we're trying to do. The FMAHealth.org website is really more of the strategic plan and professional facing website. It's where you can follow along to see what's happening in this initiative. And I actually just misspoke. The URL for this presentation actually will be at this FMAHealth.org website. The one that you can get off the Health is Primary is the video that was embedded in this presentation is posted at that website, along with the ads and the text for those that I showed earlier. So finally, the opportunity for your input, engagement, suggestions, constructive criticism. There's an email Dropbox, info@fmahealth.org. And so if you have thoughts about how this effort can be successful, recognizing how important it is not just to the specialty of family medicine and not just to our healthcare system, but to the people in our country, would very much welcome your input and suggestions. If you feel that you have particular interest and expertise to offer in the work of the tactic teams in their extended network of advisory input, you could express that interest again at this. So that's the end of the prepared remarks. And at this point, if people had questions around further clarification of the effort and what's ongoing, I'd be very much interested in doing my best to answer. So I believe Ann or Kirsten, you were going to highlight some of the questions from the chat area.
To remind folks to go ahead and type questions into the chat area. We do have a question, Glenn, for you. Have you taken this down to the state level, or are you coordinating with states that have exchanges? And how do you plan to put family physicians' names front and center who are willing to take exchange patients who are, for many, just beginning their first primary care relationship as you coordinate?
Yeah, I would have to admit that at the level of the exchange and the different plans, as far as that engagement, I would say our strategy has not evolved that far yet. The first meeting of these tactic teams will be the first week of December, and so a lot of this work remains to be done. But you're absolutely right that a lot of this work will happen at the state and local level and not necessarily nationally. So it's again, it's one of the reasons we have an AAP chapter executive on our board. We also have one of our chapter executives serving on the engagement committee, recognizing that chapter engagement will be a very important piece. I will have an opportunity to speak at the American Academy of Family Physicians State Legislative Conference that is not this coming, but next weekend, and talk to them and get much of their suggestion about how does this effort best integrate and collaborate with state-level efforts. How can we leverage each other's sort of resources and perspectives to get that success. So I would also pause for a moment and say I recognize I'm saying that a lot of these things are to be determined. We very much felt that the communication effort was best launched at the largest single meeting we have of family physicians that happens every year, and that was the assembly in D.C. But a lot of the work that was necessary to get the strategic part of the plan up and running is still in process, and it really kicks off in January. So specific to your comments about the exchanges, if you have input and suggestions about where those opportunities exist and how to best take advantage of those, that would be a great thing to send to that email Dropbox. So I'm going to back up my slide so that email address shows. But thanks for your question.
Okay. Next question is a two-part question. Haven't we heard variations on this for the past 20 years? What is different about this initiative? And then how are legislators being engaged?
Yeah, two great comments. So how this is different, I have a slide in a different presentation because I recognize that a lot of this is not unfamiliar. We've talked about need for workforce. We've talked about need for payment reform. We've talked about the need for practice redesign and better focus on health. And so what I'll tell you is different is that we've learned a lot in the 10 years since the Future of Family Medicine publication. We've learned a lot about what works and what doesn't work. This effort is informed by a substantial amount of research that has guided the development of this strategy. The circumstances have really evolved in our favor for this window of opportunity and time. I like to say that regardless of what people feel about the Affordable Care Act, that whole debate about health care reform really shined a light on the importance of primary care and how it's disadvantaged in our current system. And so people who previously did not understand that, patients, legislators, members of Congress, employers, I think are more aware than ever of that. And so I think we have a window of opportunity, and really informed by very strong, solid research. And again, that research showing that a lot of people are looking to us as the ideal people in the specialty of family medicine to step up and undertake this effort. The last thing that I would say is different is that we have to get over what I call family medicine nice. And that is that we have been reluctant. It's just part of family physician personality in many ways to appear self-serving. And we have to get over that. And the reason we have to get over that is that the things that are good to promote the strength of the family medicine and primary care workforce are what are going to benefit the health of the people in this country. And to advocate for what's good for people's health and good for the healthcare system is not self-serving. And so we are no longer going to be reluctant to stand up and advocate aggressively for ourselves. Engagement in the legislative sort of area, I think, is going to really require in two different areas. One is these 8 organizations do collaborate in their national advocacy efforts. We have had some briefing with the members of Congress through their health legislative aides, but a lot of this work likely is going to happen in other arenas. It's going to happen in state government. It's going to happen in engagement with payers and employers, and again, those efforts are underway. We do have plans to collaborate with the Patient-Centered Primary Care Collaborative, which represents a lot of not just physician and other medical groups, but again, payers, employers, health plans, other stakeholders in the group that already have a history of advocating for what's necessary for primary care. So the actual strategy, what that advocacy engagement will be, is very much in evolution, but again, another area to stay tuned, and another area where your input would be most welcome.
Another question. I'm glad this is unfolding. Many entities are already developing healthcare reform strategies to try to save small primary care practices and make it easier for them. I hope we can partner with them, but how do we sort through the lobbying or competition?
The lobbying or competition, I do very much agree that this effort is very much aligned with trying to enable the continued practice of family medicine across a spectrum of practice environments. Fixing this payment model thing is equally important to small practices as it is to large practices. We need to have the PCMH model be scalable up and down as far as size of practice. As far as competition, I think if we come together as family physicians with our other primary care specialties to advance these strategic initiatives and our values, our competition is simply that we're going to leave people in the dust. Nobody can do this as well as we can. But there is very much, again, a focus on the needs of solo and small practices in this effort, and it's why we have had a concerted effort to have a member of our board be a small town practicing solo practitioner who actually signs paychecks for them and their staff, and has that level of engagement with their practice. Somewhat separate so far from this is that there is one sector of this preserving small practice and changing the payment model is the direct primary care movement, and there's been engagement in our effort with representatives in those practices. The members who have that kind of practice were participants in our retreat, and that's where this concept of a comprehensive payment, where you move away from the fee-for-service to a global payment, whether it's paid by the patient or a health plan or whoever, is less important. So that the direct primary care model was initially patients paying directly to the practice. It's evolved. I'm aware of practices that actually accept that monthly membership payment from an employer or a union or other mechanism. But we need that model to be able to extend to other practice environments. If our colleagues that are working in large systems, a hospital or integrated delivery system, if their global payment is through an ACO bundled payment sort of model, but their payment to them as practitioners is still portioned out using an unfair fee-for-service RVU-based system, then those colleagues are going to suffer. So we need this model to be extended to any of those sort of practice sizes and models. The concept of the term comprehensive primary care payment was coined by a general internist, Alan Garrell, and I think if you look up his article, it's just from a couple years ago, he explains well the idea behind the payment model.
Okay, I think that's it for questions. We have time for one more if anybody else wants to type in questions. Otherwise, I think we can wrap it up.
Well, not seeing any other questions, I again want to thank people for their participation tonight. Again, if you have colleagues that are interested when you discuss this with them, the link to this presentation will be up on the fmahealth.org website later this week. Again, feel free to share that email Dropbox, info@fmahealth.org, for any of your colleagues that would like to have input to this. It's one of these efforts where the more input and constructive thought we can have in it, the greater our opportunity for success. So please stay tuned, and as things unfold, please feel free to offer your comments and input. So if there's no other questions, I think we're at our time, and we'll just say good night, and everyone have a wonderful evening.